How are you guys doing? So I didn't know what I was going to talk about until recently, but there's always something that gets me upset, and that's what I talk about. So I was sitting with some nursing aides, and one of them had a little sniffle, and she came up to me and said, "Could you write me a prescription for Tamiflu?" So I want to talk a little about Tamiflu, but I want to use it to discuss bigger issues. Everyone know what Tamiflu is?
Yeah.
What is it? Something for the flu. And we can antiviral for the flu. And everyone know what the flu is? We've talked about that a little. The flu is influenza. It's a very specific virus. It's not the sniffles. It's not a sore throat. It's a very specific virus. It's not diarrhea. Influenza is a virus that has lots of different strains. In certain years, it's killed millions of people. And it's usually, the symptoms of influenza are usually a very high fever, 103-4 degrees, terrible body aches that you can't get out of bed, shaking chills, dry cough, runny nose, and congestion. That's influenza. So when people have a little cold and think they have the flu, so I have people who've gotten the flu shot and then they say it didn't work, I got the flu, but really they just had a cold. The flu shot, influenza shot, is supposed to prevent influenza, which this year it didn't, and some years it doesn't, because they only take their best guess. And it does a decent job of preventing it, but even so, if you get a flu shot, you're not going to prevent all influenza. There's still a chance you'll get influenza, just your chance gets a little better that you'll avoid it. A little better, not even a lot better. But over the course of the whole population, a lot of lives can be saved if you prevent some influenza. How do people die of influenza?
Pneumonia.
Right, most of them get pneumonia, and it's bad pneumonia, and it's pneumonia in a body that's already very weak. So even if you give people antibiotics, a lot of them don't make it, especially if they have underlying illness. There are other ways people die too. Some people go into shock. Some people's heart stops. Some people get what's called capillary leak syndrome, where they actually had fluid go into their lungs and there's nothing you could do about it.
Yeah. And suddenly you can't breathe.
Exactly. And you can give fluid medicines, you go in the ICU, there's nothing you can do about it if that happens. So influenza, like all viruses, can cause problems with the entire body and cause death and major illness that's not treatable. And there's nothing we could do about that. And that's why we don't want to get influenza. So along comes Tamiflu. Tamiflu has been around for a while. And Tamiflu is recommended by the CDC, the Center of Disease Control, down in Atlanta, but interestingly not recommended by everybody. So the FDA doesn't give the same recommendations as the CDC. So we want to get into why the CDC recommends it very strongly for two or three reasons. Number one, if you think you have influenza, you should take Tamiflu. Number two, if you're in a household or in a place that has influenza, but you don't have it, you may want to take Tamiflu to prevent yourself from getting it. And number three, if you've been directly exposed to someone with influenza, like you just went on a bus and then they say, well, someone on that bus had influenza, then you take it. That's called post-exposure prevention. So those three reasons, for all three of those, they suggest Tamiflu. And for instance, if someone upstairs on the third floor got flu, then the health department in this state would force everyone else in that floor to get Tamiflu. It'll be a requirement. And we were talking about it this morning. Let's say you didn't want to get it. Would you be required to get it for public health reasons? And we don't know the answer to that. So there is a lot of compulsion to get it. So it's pretty good medicine, expensive medicine. The CDC has stocked millions of doses of this stuff in case there is an influenza outbreak. And they bought all of them from one drug company, Roche. Roche makes Tamiflu. Just as an aside, Roche donates over $1 million to the CDC every year. Drug companies in general donate $12 million a year to the CDC.
Peanuts.
And peanuts. Out of the $50 million that the CDC allows in donations, 12 million comes from the drug companies. One company, Genentech, donated money to the CDC, just $600,000. Genentech makes the vaccine, the treatment for hepatitis C. Literally within months of that donation, CDC was recommending everyone get checked for hepatitis C. So this stuff is not made up. These are New York Times, Washington Post. A lot of major researchers understand that there is a conflict with what the CDC recommends and what is in reality. So that's why it's important to not just listen to CDC recommendations, because there might be more to it. So we want to know what Tamiflu actually does. Does it prevent the flu? Now, when the CDC gave its recommendations, it stated that it will decrease the rate of pneumonia by about 40% in people who get Tamiflu. It will decrease the rate of death by 30%, and it will decrease the rate of hospitalization by 30%. I've told you guys before, when you hear percentages like that, be wary, because 30% of what? Does it go down, does the rate of pneumonia go down from 1 out of 1,000 to 0.5 out of 1,000? Because that's a 50% reduction. So we need to know the numbers, which the CDC didn't supply. So other independent researchers looked into this. And in 2014, the Cochrane Group, which is a group out of London that independently looks at data and worldwide is considered the most objective group, looked at it. But they did something different. They said, well, the CDC is just looking at published studies on Tamiflu. Now, does anyone know the difference between published and unpublished studies? First of all, I don't want to sound like a conspiracy theorist, but these are just the facts. It's 98% or so of all clinical studies are done by industry, by drug companies, by device makers, by someone who's selling a product. And they will publish what they want and not publish what they don't want. So if a study suggests something doesn't work, they won't publish. So when you're just looking at published studies, you may get biased results. And that's what Cochrane found out. And they said, we can't just look at what they published. We want to actually look at what was unpublished. And they actually got permission to do that based on the fact that in England, they would not sell any drugs from these companies unless they also had the unpublished data. So they got access to the unpublished data in 2014. They tried to share that with the CDC, who said they didn't want to look at it. So that was all in the newspapers in 2014. What they found when looking at the unpublished data is that, for instance, in the pneumonia prevention, they said it reduced it by 50%. The actual number of people who benefited were 10 people out of 1,000 prevented pneumonia. But that was based on self-reported pneumonia. So they asked people, do you think you have pneumonia? When they actually looked at the data of people with proven pneumonia, how many people had pneumonia prevented, the number was straight out 0. When they looked at how many hospitalizations were prevented, it was 0. When they looked at how many deaths were prevented, it was 0. Those 3 numbers were 0. So no deaths prevented, no pneumonias prevented, and no hospitalizations prevented in people who took Tamiflu versus who didn't take Tamiflu. The reason this is important too is I read an article in the Washington Post a few weeks ago that got my ire going a little. It talked about a woman, a mother of 4, down in Florida who died of influenza. And there have been people this year dying of influenza. It's a nasty strain of influenza this year. People are dying of it. And the article was very specific to point out, they said, the reason she died is because she refused to take Tamiflu. So it was very explicit in the article. And there was no counter argument that maybe that's not the case. And we know that that's not the case. It doesn't prevent you from dying. People die at the same rate who take Tamiflu as who don't take Tamiflu. And so to make a blank statement like that just scares people. Because what does Tamiflu do? it does reduce the duration of your illness. That's what it does. So that's its main thing. So the average person with flu, the influenza lasts 7 days. One good thing about influenza is it's nasty, but it ends. A lot of you guys who have had other infections know they can go on for 2 months. They're low level, but they don't go away. Influenza is done after a week. People who took Tamiflu, so 7 days for people without Tamiflu, 6 1/3 days for people who took Tamiflu. And that is considered about a 30% reduction, right? If you use those numbers in symptom duration. The other thing is symptom severity. How bad is your flu? Did not change between those two groups. So the 2/3 of a day that you buy are not a bad that's when you're not so sick. It lingers a little longer at the end if you didn't take Tamiflu. So it does decrease duration by that 2/3 of a day, but not the worst. You're still going to be really sick when you're sick. There was some evidence it did help with prevention. So in people in a large group where there were a lot of people with flu, if they gave Tamiflu to one group in there and not another group didn't have Tamiflu, out of 1,000 people, 10 people avoided the flu. In addition, compared to the people who didn't get it. So 10 out of 1,000. So not a huge number, but those people avoided the flu. None of those people who avoided the flu avoided hospitalization, death, or pneumonia. So there was no serious difference. No life-threatening difference between, even in prevention, in the people who got Tamiflu and didn't get Tamiflu. So all that's well and good. You could say, I have influenza and I'm going to get Tamiflu because it'll save me 2/3 of a day. But that's all you can say. Or you can say, well, all my family has influenza, so I might take Tamiflu to prevent myself from getting it. But even in that case, you're not going to prevent serious outcomes. People still got the flu who took it, and those who got the flu got bad flu sometimes. The flu it tended to prevent is mild flu. That's all it did in a very small number of people, 1% of people. So it didn't have a huge role, so you could say, well, 1% is better than nothing. That's all you can say about prevention. But what's the downside of Tamiflu? Is there a downside of Tamiflu? So cost is one. It's a very expensive medicine, and if we're thinking about our healthcare system in general, and we're good stewards, then we'll care about that. But most of us as individuals could care less. That's just normal. If we're going to feel better from it, we're not thinking about the health system in general. But so even if you look at it as an individual, Tamiflu has side effects. The scariest thing about Tamiflu, I think, is that most of those side effects have not been looked at in people over the age of 70. And there's a lot of anecdotal evidence that when people are older, the side effects are far worse. Anecdotal means we just base it on case reports of, let's say in a nursing home, X number of people got this and a whole bunch of them got sick. That's anecdotal. That's not a study. You can't rely on that. But that's all we got. So we have to look at the data in younger people. So it's not a horrible medicine in younger people. So the side effects are kind of mild. So it was 30 out of 1,000 was the number I found. I had to convert all these numbers over because they use this thing called number needed to treat, which is so confusing. So out of 1,000 people, 30 people got headache on Tamiflu, and 30 people had nausea and vomiting. And 10 people had major psychiatric changes out of 1,000 people. They got really confused or psychotic or hallucinations. So about 10 out of 1,000 got those. And the thought is in people with dementia or who are older, those numbers will be much higher, especially with dementia. If you give this medicine to someone with dementia, which the drug companies have carefully excluded everyone with dementia from these studies, but they think the psychiatric problems will be much higher. Which of course, when you're talking about giving this to everybody on the third floor, if one person gets flu, what's the potential harm you're causing? It could be pretty large in a group of people with a lot of dementia. But that's what the health department would have us do. People with nausea and vomiting who have other illnesses such as congestive heart failure, atrial fibrillation, might be on Coumadin, hypertension, diabetes, might have problems from that too. So it could cause potential harm to a certain group of people. So you have to be careful when you take this stuff. It doesn't come for free, not cost-wise or side effect-wise. So you have to really think about whether this is a drug that you want to take if you have influenza. And a lot of people, when they get sick, say, just give me anything. That's kind of the view. I don't care. Just give me anything. That's the way it is. We've talked in this room about dementia drugs in general and how clearly, definitively, without any doubt, they don't work after a year. We know that. That is so established in the literature that placebo probably works better than they do. But at the very best, they can say they work the same as placebo. Though the people I know, again, who have studied this past a year, and no drug company publishes data after a year. That's their right. But there is data. It's just not been published. Is that the placebo arm starts getting better than the drug arm after a year. So that's why everything ends in a year. Despite that knowledge, and despite even the benefit is so small that it's not noticeable by people. It's only noticeable by testing. Even the best benefit you can find, nobody notices. So what's the use of it? Despite all that, people go on these drugs at the cost of $2 to $3 million a year. And neurologists and psychiatrists prescribe them like they're miracle drugs. Because dementia is a terrible illness. And you're just hoping, beyond hope, that you're going to get something. And the data doesn't seem to matter. Nobody cares about the facts when you have illness. We worked with an insurance company recently, and we're trying to make these videos, 3-minute videos. I think I mentioned this, to show to people about what risks and benefits are of different drugs and procedures. And we asked them what the first one they wanted done. And they said back pain. They said MRI and back pain. So they said because everybody who has back pain wants an MRI. You know, as though somehow that's going to help their back pain in some way. And the reason is that MRIs are very specific tests that can potentially show you, where the pain's coming from. And if you know where the pain's coming from, maybe you could treat it. If you don't know where the pain's coming from, how could you treat it? I mean, it makes sense, except for the fact of reality, which is that 85% of people over the age of 70 have some kind of abnormality on their MRI on a good day, when they don't have any pain. So how do you know that what you find in the MRI has not just been there forever? And God forbid you treat something thinking it's causing the pain when it was there forever, because now you're really causing a mess. And secondly, we also know that people who get MRIs versus people who don't get better at exactly the same rate. Even if they get procedures, injections, surgery, that if you look at 6 months down the road, they're the same in terms of their improvement. So the MRI hasn't actually helped anything, other than getting people really nervous sometimes, because MRIs find stuff. Well, your back, you got a little this, but we see this nodule over here. MRIs are famous for finding nodules, somewhere. We don't know what to do with it, so we're going to repeat it in 3 months, and then again in 3 months. This is every day for me. I find this kind of stuff. So again, that's an example of my back hurts. Here's this test. I want to do it. And I have patients who are actually very rational. I can't say I'm not going to be this way. And they say, I don't want any of this stuff. But when their back hurts, they want the MRI. That's just the way we are. We're creatures of, I know actually this probably doesn't help me, but I want the MRI because my back really hurts. It's the idea that we want something done. I think Tamiflu, when I saw this stuff with Tamiflu, that kind of reminded me of just this idea that we're fighting against all the time in the medical system, of there being a lot of very bad interventions that don't help anybody, or potentially harm people, that are being touted by the highest levels as being life-saving. And it goes from the CDC into the New York Times, into out of the doctor's mouth, and then what are you going to do? You think this is life-saving, and then all of a sudden, you say, well, I'm going to use it for everything, not just influenza, because I'm not sure exactly what influenza is. But I know people are dying of it, so I'm not sure I have it. So I want it for everything. We're getting 3 or 4 calls a day at our office for Tamiflu. And we give it to them. Because I can't have this discussion that many times. And when people want it, we just give it to them. Well, it's my obligation to tell them that they can get nauseous and headaches and potentially psychotic. It's not common, but it can happen. And that it's never been proven to work. So I'll do that, but they all take it. They take it anyway. But again, the idea that so much of what we're doing has dubious benefit, and yet there's no crime for the highest organizations of our country to say that they are beneficial. How have we gotten into that situation? It's really mind-boggling to me that we're there. The anger of people writing about Tamiflu is incredible. I know one guy named Peter Doshi who writes for the British Medical Journal, BMJ, and he's been writing about this for a while. And I know who he is, and he's a respectable scientific researcher. And he's gotten crazy. I mean, it's literally, he's almost gotten insane because he cannot accept how this myth is not going away. And I read some things about him written by the other side, and they call him, an immunization denier. They labeled him and stuff to try to make him seem crazy. It's kind of like the guy with the statins, the head cardiologist over at Cleveland Clinic, who says that anyone who thinks there's a side effect from statins is making it up because the internet is clouding their mind. So they're making other people who seem crazy, who have some problems with this, and then all of a sudden you think maybe they are crazy. Maybe I should be taking this stuff. I see that all the time where people make a decision, for instance, to go off a dementia drug, and then they start hearing, well, my wife was on the drug and now she's much better. I don't know what you're doing. And so then they change their mind. They say, God, I must be missing something. It happens all the time. Society has a big impact on how people make decisions.
If you find that you're in a situation and you've got somebody next to you coughing and carrying on, and you go home, I sometimes take vitamin C because I remember Linus Pauling. So I take maybe 1,000. Is that harmful?
Okay, so that's exactly the next thing I want to talk about. Is when they do these studies on drugs like Tamiflu, they don't want you taking vitamin C. They don't want you to do what we know prevents flu. They don't want any of that stuff because that'll cloud their results. So they have certain exclusions. There's a guy out in, I'm blocking on his name because I have too much I think about. And plus I have early dementia. But he's a guy in Stanford who looks at studies and looks at how studies are designed. And his conclusion is studies are designed by real experts who know how to design them to get the result they want to get. They will pick the people who enter the study. They will pick the exclusion criteria, how much drug is given, how long you're going to give the drug, based on knowledge they have that will show that this drug will work. And that he conclusively shows in all his studies, and he's another guy who's considered crazy, but they're not getting rid of him at Stanford, and he gives lectures all over the place. But they consider him crazy because he's got this paranoia and conspiracy theory. But he's shown that these companies do design studies to get what they want. And interestingly, sometimes years later, when the drug becomes generic, they design another study showing it's not effective because they have a new drug out. So it's amazing how often that happens. And both times, there's the people who design who carry out these studies are places like Harvard and Yale and Stanford, and they know for them to get in the New England Journal and get in the New York Times, they got to take this drug company money for the study. It's because they're the only guys paying for studies now. So they got to take it and they got to follow the protocol that was designed by those people, and then they will be the spokesman for the success of the study. And they'll also be the spokesman for when the study is debunked years later. And they get 2 publications. And he showed that too. He showed how many of them get 2 publications. So the reason I bring that up is because when they've done the Tamiflu studies, they don't look at the stuff we know that might help prevent flu. So what prevents you from getting influenza? We don't know about vitamin C because it hasn't been well studied. You know, Linus Pauling was quite adamant about its effect, and you have to take a lot, but he never studied it. And we don't have any studies other than little piddly studies, some of which show good, some of which show harm, but nothing dramatic. And there are other potential things too, like echinacea, like even turmeric, that could potentially enhance your immune system. What about eating the right way? What about having a diet heavy in fruits and vegetables, low in carbohydrates, so your immune system is more effective? How about that? How about not having too much alcohol or don't smoke and other things that make your immune system effective? Or probiotics, which we don't know how that, because we know the gut bacteria has a big role in our immune system. So maybe there are ways to make our immune system work better, not just taking this relatively useless, expensive drug that we could do by changing our lifestyle. Has that study been done? No. And would Roche compare Tamiflu to that? They'll never do that.
But it can't hurt you. You said once you just pee it out.
Yeah, and my feeling is that when you want to prevent the flu or any infection, you should do all that. You know, Tamiflu is an unproven therapy, well, with harm and high cost. You might as well do an unproven therapy not with harm or high cost. And we know that eating the right way and exercising improves our immune system. That is proven therapy. It's never been studied with the flu, but we know that it improves the immune system. So why wouldn't you do that? That's the way to do it. And how about preventing the flu from getting the flu? Is the best way to prevent getting the flu, if people in your household have it, to take Tamiflu? Or are there better ways to prevent it? Proven ways. Like washing your hands all the time. You know, hand washing is how you prevent the flu. You know, making sure that when your hand touches your mouth after you've touched things in the community, whether it's a door or silverware, that you wash your hands. So if you come into the dining room and you've touched a few doors or elevator buttons and you pick up a fork, you wash your hands before you start eating. And so you kill whatever virus someone may have sneezed and taken your fork and put it on the table. You don't know that. And they may end up getting the flu and then you get it. But if you wash your hands, we know that works. And we don't know that Tamiflu works. So why wouldn't the CDC come out and say that instead of everyone needs to get Tamiflu? We don't know. We don't think masks work. We don't think, they're not going to prevent you from getting it. They might prevent someone from spreading it, but they're not going to help you because you don't get it that way. You know, you get it from your hand to your mouth. So whether you're wearing a mask or not, once it gets up here, it's going in. So we don't think of that. I've seen a lot of people walk around with masks, and I ask, are you sick? They said, no, we don't want to get sick. But that's not going to help. So we know there's definitely proven things you could do. And certainly if there's an outbreak in a place like this, the best thing is just don't go out. You know, don't go into a communal area until the outbreak is done. And while you're waiting out of the communal area, eat a lot of fruits and vegetables, get enough sleep, take care of yourself.
Has there been here that you know?
No, there hasn't.
Thank God for that.
Would you encourage the dining room and the planning to have more fruits and vegetables?
I always encourage more fruits and vegetables. I know when Niles was here, we talked about that all the time. And I don't know if it ever happened then either. But he and I used to sit out and give a talk about the importance of antioxidant diet and fruits and vegetables and grains. And he had this big spread out all the time. And a lot of people told me, that's great, this is the only time we see the spread. So I don't know what you guys are actually getting.
Things got onto the regular menu.
Did they?
People didn't.
Then they didn't eat them.
Didn't need them.
Yeah, so they disappeared.
People won't walk to the salad bar.
Yeah, so that's exercise plus fruits and vegetables, right? If you walk to the salad bar. But yeah, I don't know how many fruits and vegetables you guys have available to you. But it's definitely, the best diet is one very high in fruits and vegetables for every medical condition known to the human race.
Well, there's always fruit on the salad bar. There's always
Yeah.
Fruit to take out.
And fruits, they let you take it out?
No.
Or you have to hide it.
Yeah.
You bring some bags, yeah.
That's crazy.
It's-
In a bowl to take out.
Yeah, if they're free to take out, that's good.
Yeah.
I know, like up on the third floor, the fourth floor, there's fruit all over the place. Because I've taken it from
Does
there.
that mean that you have to wash your hands between each patient?
Yeah.
Oh, at least.
Yeah.
Between each one?
For my own safety. I have to wash hands
Between
between each.
patients, yeah, right.
But I have a little squirt bottle. And the thing is that for respiratory illness, those little squirt bottles are effective. For GI illnesses, they're not. For GI meaning diarrheal illnesses, you usually need soap and water. But for respiratory illnesses like influenza, they're fine. They have them around.
Yeah.
Yeah.
they're-
Does airborne help? An airborne tablet?
I don't remember what's in airborne.
Zinc and
Zinc.
vitamin C.
Okay. So
You
you know,
can take on your own.
so I mean, there's some evidence that zinc shortens the duration of these illnesses too. And it's interesting that the amount that zinc shortens it, they consider inconsequential. But it's the exact same amount that Tamiflu shortens it. It's about that much. It's about 20%, 10 to 20%. And they call that inconsequential, but Tamiflu, it's a major breakthrough. It's amazing how you could take one number and use it two different directions. Zinc has been, not as well studied, but that seems to be what it does. It shortens the duration of illness a little bit, by a few hours. And maybe the severity too. And then vitamin C, again, we don't know, but
Can't hurt.
can't hurt. Chicken soup might be good. I mean, seriously, people who have that kind of brothy vegetable stuff, it might be useful. And, again, the big studies aren't, wouldn't it be great if there were big studies on these things? Because then this is what we would be doing to treat all illness. But, it's gotten to epidemic proportions how many people are requesting Tamiflu in this country right now. And it's costing a lot of money. And, like I said, the CDC has stockpiled it, and a lot of pharmacies have stockpiled it, and they want to sell it. They similarly, I heard this in the news coming in this morning, they were talking about the flu epidemic, and they say the CDC is still recommending you to get a flu shot even if you haven't.
Yeah.
Well, it doesn't work this year. I mean, it's just ineffective this year. They said it works 36% of the time. That's not, it's working on the influenza strains that aren't getting people sick. The influenza strains that are getting people sick, it doesn't work for. It wasn't in the shot. So why are they still recommending it? Because there's a lot more to sell. That's cynical me. They got a lot of flu shots out there that haven't been used because once a lot of people found that it didn't work, a lot of people didn't get it. Because, even though they were told to get it by their doctors, because we have to tell you or else our quality indicator score goes down if you don't get it. So we do try to sell it, push it on you anyway. You gotta think for us too. I said to someone, I gave a talk somewhere about, and it's even on my podcast this coming week, about how much of what we do as doctors actually makes a difference in your outcome. It's a very small amount. But I said that should not stop you from going to see your doctor. Because we still need you guys to come. We don't want to get the wrong message here.
Are there any other countries that have better records relative
Oh,
to
yeah.
this kind of thing?
Yeah. Oh yeah. In Europe, it's much. I always look to Europe, and so when I got the records, so I talked to you guys about statins and calcium score. And this country is already totally tainted in terms of their view of statins. So I found this great report from New Zealand, from the Cardiology Association in New Zealand, that really showed all the data about, when statins, so if your calcium score was this, how much does statins help? Calcium score was this. And it was really revealing because even people with moderately high calcium scores, if they lacked other risk factors for heart disease, their benefits from taking statins were infinitesimally low. Even people with high calcium scores, 400.
I see.
Even a relatively high score,
Like 400?
400.
Oh.
So below 100, there was no benefit no matter what.
Well,
And here they call zero. Here they say you have to have zero in this country.
Well, the
Even if you
talk-
have one.
the talk you gave prompted me to go and get a calcium score, which was under 100, and I'm not taking statins anymore.
So there you go. Your risk is if you have no plaque, there's nothing.
Yeah.
Nothing could break off. But people even with 400, they found that who had no other risk factors did not benefit from a
400
statin.
or
Now,
For what?
400 is the calcium score. So they score it out of about 2,500, how much calcium is in your blood vessels.
Okay.
So to understand too, there's a big false positive in calcium scores, because when you get older, you could have calcium in your blood vessels. So you're measuring the calcium in your blood vessels, because blood vessels calcify when you get older, but all you care about is the calcium that's in the plaque, but they can't tell the difference between that. So you could have a high calcium score and have no plaque at all, or have plaque, you just don't know. I had a guy who had a calcium score of 2,500, and he went and got everything done, and he didn't have an ounce of plaque in him. But he had it all in his blood vessels. But we know if it's low, that you don't have plaque. You know, we know that much. And again, this New Zealand set of recommendations was reasonable. You will not find that coming out of this country. You won't find recommendations like that. You have to look to Europe. This Cochrane is the best source that I've looked at. We have the U.S. Preventive Service Task Force, and even they are a little off base sometimes. They don't use all the unpublished data sometimes. They will include a lot of drug company data.
400 per what? 400 per milliliter of what?
They just score this based on 2,500. So 2,500 means your whole blood, all your blood vessels are calcified. So it's a CAT scan score. It's a CAT scan score that they come up with. Yeah, it's not a blood test. So they just score it, they come up with a number. Yeah, they have a scale, and so your number goes along the scale. 400 means you still have a decent amount of calcium, right? That's still, but they say that, yeah, you might have calcium, but the statin's not going to help the outcome. You know, which you can interpret two ways. Like, okay, the statin's not going to help, I must be okay, or the statin's not going to help and I'm in trouble anyway. Which could be either one. But the real thing you want to know is, what could I do about it when you get a score like that? And again, I look to other countries. And again, we know if you have a lot of calcium in your blood vessels, then fruits and vegetables and exercise make a big difference. So we know that. So that's in one way you could approach it. But the information that's disseminated from this country is very different. And the CDC has come under a lot of fire lately because of this. And I think I told you I wanted information about the new pneumonia vaccine from them, the Prevnar, just to find out what the benefit was, because because they were recommending everyone get both studies. They came out with a strong recommendation that you should get the Pneumovax and the Prevnar, both. And I wrote to them, and I actually got an answer from a pretty high up guy in the immunization department. But I wrote to them and said, there's only been one study on Prevnar. It was done by the drug company, and it was done in the Netherlands because nobody in the Netherlands gets pneumonia vaccine. So it was specifically done on people who have never had the pneumonia vaccine. So I said, how could you recommend them getting both when you haven't studied it in people who get both? And their answer was, well, the pneumonia vaccine does this, and Prevnar does this, so we just assume that's going to happen. But you can't do that. You can't make those assumptions. We know as doctors that often, falls flat in the face, that some things are counterintuitive. If you give two things for the same purpose, they sometimes cancel out. You get sicker. We know that for cholesterol, for instance. So this was an example of the CDC giving information that has become a clinical practice guideline. So if you guys don't do it, we get in trouble. That has no basis of fact. One study, drug company study, very limited population, and by the way, the benefit was so small, less than 1 out of 1,000 in the Prevnar wing, which is the same benefit in Pneumovax. So does that mean it's 2 out of 1,000 if you add them both together, or is it the same 1 out of 1,000, or is it less than 1 out of 1,000? We don't know. So why are they recommending it? But that's our CDC. And it turned out from a New York Times article 2 years ago that the people in that immunization group in the CDC, a lot of them worked for Pfizer previously and had Pfizer stocks, and Pfizer makes the Prevnar. So a conspiracy theory again, which I don't want to think is the case. You don't want to think that's going on, but you get nervous about it when you see that. So there are a lot of scientists in this country, a lot of university doctors that are just not listening as much to the CDC, which is a shame because the CDC you really rely on to give you accurate information. And the FDA is the same way. You know, the FDA gets, you know, they will approve drugs, you know, based on the fact that a lot of the people who work in the FDA were part of industry. And that's a well-known fact that they have a lot of industry ties. Is that a big deal? You know, I don't know. You'd think that people were able to divorce themselves of that once they enter a more objective agency. But there's a lot of talk in the newspapers and in the medical literature that that's a problem in our country. There's not as much in other countries.
You spoke of fruits and vegetables. Are there particular fruits and vegetables that are helpful and some that are less helpful or not helpful?
You know, the general, the question is, are there certain fruits and vegetables more helpful than others? The big fruits and vegetables that everyone talks about are berries. Everyone loves berries. And so they're very strongly antioxidant. And it almost doesn't matter what kind you eat. So we know those. But when they've done these longitudinal studies, which are the studies that look at people over 20 years, like the Framingham Health Study and the Women's Health Study, Baltimore Longitudinal Aging Study, it's just the idea of eating fruits. And the people who had the most fruits and vegetables tend to have better outcomes. So they didn't even break it down into what people ate. So it doesn't seem to be a very specific thing. If you look over, you know, even things like grapes, which are the highest sugar content of all the fruits, also are very strongly antioxidant. So they're good. It doesn't seem to matter very much. Apples are terrific. Apples, interestingly, exhaust as many calories to absorb them as they give you. So they're almost calorie neutral foods. But they're very strongly antioxidant. And you know, an apple a day keeps the doctor away. We knew that a long time ago, that people who eat a lot of fruits and vegetables do better. You know, there's not new information out here. It's just kind of been hidden. It's been hidden and it's creeping back again. That this is what we should probably be doing. And we also know that fruits and vegetables are problematic because they're shipped from halfway across the world sometimes, and they lack a lot of the vitamins when they're shipped that way. So we had our own problems figuring out how to get the best fruits and vegetables. And is organic better than inorganic? We don't know, but we kind of know local is the best way to go. So eating seasonal stuff is better, or frozen stuff. When things are frozen, they are picked at the right time.
But one can also be allergic to some vegetable.
Oh yeah.
And
You could be allergic to vegetables.
Quite a bit.
You have to definitely, you have to know all these foods that are good for you are not necessarily good for you. You have to figure out what's bad for you. You could have certain fruits and it just destroys you. So you have to be aware of that. Everyone's an individual here. I don't want to extrapolate that everything's good for you. Some people get a lot of gas from some of this, and that's not worth whatever benefit it derives. So you just want to eat kind of healthy though. But again, the idea that I wanted to bring out with Tamiflu is the idea that you can't necessarily rely on a pill to do these miraculous things. So a lot of people think with influenza or flu that they don't have to worry as much because they got this pill out there, and that's a shame because you got to be scared of influenza. Certainly, it's bad. It could be really bad. There's a bad year, so you want to prevent yourself from getting it, and you want to take all precautions. And you want to eat well and keep yourself. Don't be up all night. And you want to stay away from people who are sick and wash your hands a lot during flu season, which is going to be another month of flu season. And don't think because you have the flu shot it's going to help you. Don't think there's this pill you can reach if you get it, because none of that's going to work in the end. And what really hurt, it really hurt to see that this major newspaper is blaming this woman for her own death because she didn't take a pill. I mean, that kind of stuff is uncalled for. That's not that way. That woman was actually intelligent not to take the pill, and she died by unfortunate circumstances because she was unlucky enough to get a terrible virus, which can happen to any of us at any time. Luck is a big part of our lives. We don't know what the rest of the day is going to bring.
It's true.
So, any questions about this stuff?
Is there another kind of flu? When we were kids, flu was gastrointestinal stuff.
Yeah, flu has taken on a meaning all of itself. Flu is influenza. That's actually the only thing flu should be. So once you start using the old terms that used to fly around, because there's the stomach flu, right?
Yeah.
So that was, but that's not flu. That just kind of came because influenza was around, and they say, well, this is stomach influenza, but it's not influenza. You know, there are a lot of other viruses that cause the stomach bug, but not influenza. So then once you call the stomach flu, then you think, okay, a flu shot might prevent it, or Tamiflu might prevent it. And I got a lot of patients who think that. They said, well, I got the flu, and I took the shot. I said, what do you got? Diarrhea. I said, you don't have the flu. Yeah, I got the stomach flu. It's this use of terminology. Just like I said, the pneumonia vaccine is not a vaccine against pneumonia. It's a vaccine against pneumococcus, one bacteria that causes some pneumonia, and among other things, but so many other bacteria cause pneumonia. So if you get the pneumonia vaccine and get pneumonia, you say it didn't work. But that didn't mean it didn't work. You just probably got a different bacteria that caused it. But once we start using this false terminology, we get upset when things work or don't work. Because we have this idea that if we get a certain shot, then we're good. If we get a certain medicine, we're good. Nothing bad should happen to us anymore.
How often are these illnesses cultured and really scientifically identified?
So how often are these illnesses cultured and identified? Certainly in these studies that are done, they all have to be cultured and identified, except for the fact, like I told you, in several of the studies, they gave self-reported pneumonia. Do you have pneumonia? Yes, I think I do. Okay. So you have to be aware of that when you're, so a place like Cochrane, unless they are cultured and identified, they don't call it pneumonia. They won't do that. In the real world, you know, we're doing a lot of flu influenza swabs, but they're not 100% accurate either. So there's a lot of false positives even with those. And that's a problem because they're not cultured. So the swabs we're using are a quick test, not based on a culture, but based on a chemical assay, a chemical test that may or may not show you have influenza. So you could have false negatives and false positives. So that means you get a swab that's negative and have the flu, and you can have one that's positive and not have the flu. There's a certain percentage of people, and maybe upwards of 10%, who are in those categories. So 90% sounds good until you're doing it over thousands of people, and then how many people are you misdiagnosing? Hundreds of people. So so it's not totally accurate. But again, since there's no treatment for influenza, and since if you have influenza, you treat it the same way as if you have a cold, which is, someone told me upstairs, they said, yeah, I had a really bad virus, and I didn't take the Tamiflu, but I found that Robitussin cold and flu helped me. Well, yeah, I mean, that's right. Treat the symptoms. That's all you can do with this stuff. Ibuprofen has been shown to be the most effective treatment for bronchitis and sinusitis when it's given in a placebo-controlled trial. Antibiotic, placebo, ibuprofen, who gets better faster and who feels better. And it's always ibuprofen, always wins. Even bacterial bronchitis, ibuprofen still wins.
Why?
Because people feel better. They feel better. So they think they're done with the illness. So they report their symptoms are better, and they report their illness ended sooner. And antibiotics don't work anyway because they don't work for those kind of illnesses. So they work the same as placebo. And you get a bad virus, you're achy, you feel miserable. So if you could take, not everyone can take ibuprofen, same thing. You have to know what you can take and what you can't. If you have congestive heart failure, if you have kidney disease, you have bad high blood pressure, you have ulcer disease, you can't take ibuprofen. So you're out of luck there. Then you take Tylenol, which is safe but not as effective. But if you take ibuprofen, you take something for your sneezing, you take something for your coughing. And I have people who say, I'm taking all that and I'm still sneezing and coughing and I still ache. That's right. You're still gonna. You're not gonna erase all the symptoms. You can minimize them a little. You gotta drink a lot of fluids. You should be up and moving around as much as you can. You shouldn't be lying in bed because that's what causes you to get pneumonia if you lie in bed. because it all settles in your lung and you're not moving your lung. So that's why all these people get pneumonia. So you want to take medicine that allows you to get up, sitting up, moving around, keeping well hydrated. That all helps you to prevent pneumonia. That actually has been shown. But yeah, you treat the symptoms, and that'll help you more than anything.
Oh, I was just gonna comment and ask, would you comment on the possibility there might be a conspiracy of grandmothers to promote chicken soup?
Yeah, there is a conspiracy of grandmothers to promote chicken soup, and unfortunately, they're not getting their word out as much. There used to be this book, Chicken Soup for the Soul, Part 1, Part 2. It had all these remedies, all these little remedies.
You're talking about bone broth now.
Oh, bone broth, yeah.
Well, that's, if you
That's
just
chicken
go
soup.
with chicken soup.
It should be bone broth. If you make good chicken soup, you got the bones in there. That's right. Yeah, but what does chicken soup have in it, though? It has fluids, salt, and vegetables. The chicken may not even be important, except for the bone part.
Yeah.
That might be important. But it's got stuff in it, helps you feel better.
It's got mother's love.
It's got the heat. It makes you feel better. That's all it's doing. It's not curing the virus, certainly. But yeah, anyone, when I was growing up, you better have the chicken soup. So there was a conspiracy. Our generation is not pushing our kids to do that. But we have, you guys have probably seen it, we have shifted from doing that kind of stuff to thinking we should take a medicine. Our whole outlook has kind of shifted that way. I'm not going to say that anyone got better having chicken soup, but probably people felt better having their mom give them the chicken soup. The whole thing. It was just a lot nicer.
Because
Yeah.
we here at Advantage House have a big disadvantage because we don't have any grandmothers to go to.
That's right. You are the grandmothers. You're the grandmothers and grandpas. You rely on the grandkids. They're a nice generation. They take care of everyone. Any other questions? I've always told you guys this. I want you to be a little doubtful, dubious, whatever word you want to use, when you hear these bold proclamations
Cynical.
coming out, cynical. And some things work. I'll tell you, when I'm injured running and I take an ibuprofen 800 milligrams, I could run much better. I know there are certain medicines that work, and those same medicines, if I took ibuprofen every day, will cause me problems. I will have lots of problems if I did that. So you have to kind of weigh. I'm not telling you all medicines are ineffective, but when their effectiveness is usually a lot less than they advertise, because they're using those fake percentages, 50% reduction kind of stuff. And number two, they are often using studies that are totally invalid. So you have to just take a deep breath and say, is this really going to work? And by the way, COCHRANE, Cochrane, on the internet. You can look up anything on that site and see what they think. Look up any test, drug. If they've looked at the data, like I looked up medical marijuana on that site, and they said there's no data. So they're quick to tell you that when there's no data. They say there are about 40 studies and none of them are valid. So and they will only use studies with certain criteria. So you can look up anything there. And they keep redoing it every few years. Their review on Tamiflu had changed from 2010 to 14 because they were able to get these unpublished studies. So they made a different review. And that made the newspapers in 2014 when it came out, but didn't change behavior.
It's hard to change behavior.
It's hard to change behavior. Okay, so don't get the flu and then it's moot. It's a moot point. Okay, I'll see y'all in a couple weeks.